From the very moment a chemical compound enters the human body, it triggers a highly complex biological calculation. The primary objective of pharmacotherapeutics is to achieve a desired beneficial therapeutic outcome. Every intervention must also prioritize the minimization of risk associated with adverse side effects. These two requirements create an optimization problem, securing the maximum medical benefit with the least amount of physiological harm. Essentially, it aims to provide the maximum benefit with the least amount of harm. Every clinical intervention functions as a bounded exercise in physiological risk versus reward. Public perception often assumes that the only goal of medicine is to completely eradicate a disease. In practice, pharmacology operates across several distinct categorized physiological objectives. These specific goals are organized into an 8-part pharmacotherapeutic matrix that dictates why a drug is chosen. Identifying the specific clinical objective is the first requirement of any drug therapy. The most direct intervention is the curative objective. This involves the complete eradication of the underlying cause of an illness to return the patient to full physiological health. This vector represents total elimination, using antibiotics to clear a streptococcal infection or antivirals to cure hepatitis C. To stop a disease before it takes hold, clinicians use the prophylactic objective, protecting a person from acquiring an illness or preventing complications. Vaccines are the primary example of this defensive strategy, used to prevent infectious diseases like polio. Prophylaxis also includes the use of anticoagulants, or blood thinners, prior to surgery to prevent the formation of blood clots. Eradication and defense form the clinical frontline, designed to either destroy the threat or block its entry entirely. For chronic, incurable conditions, the clinical strategy shifts from eradication to long-term management. This is the mitigation objective, to control the disease, slow progression, and maintain stability. Clinicians use antihypertensives for safe blood pressure or antiretroviral therapy to keep HIV undetectable. The replacement objective addresses internal physiological deficiencies. This pathway supplies essential chemicals, hormones, or nutrients that the body has failed to produce on its own. Providing synthetic insulin to a patient with type 1 diabetes is a primary example of replacement therapy. This same objective applies to simpler interventions, such as giving iron supplements to treat iron deficiency anemia. When a cure is not an option, the goal is to enforce systemic stability and simulate normal physiological function. The final direct intervention focuses on the patient's subjective experience of a disease. The palliative objective is used when a disease cannot be cured or is actively running its course, shifting the priority to alleviating patient discomfort. This includes using acetaminophen to reduce a fever caused by a common cold. In advanced clinical cases, it involves using opioid analgesics to manage severe pain in terminal cancer patients. Palliative therapy accepts the presence of the disease and optimizes the therapeutic equation for comfort rather than correction. These 5 active interventions are governed by 3 systemic roles. The first boundary is the mandate to ensure safety and minimize harm. All drugs must be carefully monitored to avoid toxicity and adverse drug reactions. For example, clinicians adjust medication doses based on a patient's kidney function to prevent a drug from building up to toxic levels. The final 2 boundaries are quality of life and cost-effective therapy. Quality of life ensures the treatment is not more burdensome than the disease, allowing the patient to live functionally and independently. Cost-effectiveness requires achieving the best medical outcome using economically viable options that remain accessible to both the patient and the healthcare system. A drug is only clinically viable if it remains within the boundaries of safety, patient functionality, and economic reality. The completed pharmacotherapeutic matrix shows how active treatment pathways are verified against systemic constraints. This taxonomy of goals ensures that a drug's mechanism of action matches the patient's physiological needs. Selecting the exact operational objective, whether to cure, prevent, mitigate, replace, or palliate, is the critical first step in all drug therapy. Efficacy is reached when the interventional goal is successfully executed within the constraints of patient safety, quality of life, and economic reality.